is the one just pointing those facts out. So, multiple anesthetics were associated with learning disabilities. However, these patients received halothane. And the problem with this is that they also received surgery. So why are we being blamed for it rather than what the surgeon is doing for this thing? The Mayo Clinic went down and did a third round study on the same database, looking for attention deficit hyperactivity disorders. And they found very much the same thing of multiple exposures increased the risks for this. Another group in New York for a similar study looking at the Medicaid database, identifying children who had hernia repairs before the age of 3 and matching them with a control group. The outcome again looking for either diagnostic code for unspecified delay, behavioral disorder, mental illness, etc., etc. And very much similar findings. Anesthesia exposure does occur it. Age seems to be a related trend. So like everybody else, they went back in and said, let's have another look at it more carefully. And again, found out that increased problems perhaps with a diagnosis of behaviors cognitive defects. The trouble is, again, when you look closer at it, it didn't change the number of kids who achieved and did adequately in school for it. This is an observational study. You didn't know what again, having similar things, finding contradictory phenomena. In summary, we've also done studies with regard to congenital heart disease as far as there. But I find it difficult to believe that when you've got a patient having this sort of monitoring and things going on in it, to blame the anesthetic to be the problem in these cases. In summary, for all retrospective studies, you really cannot differentiate between the potential effects of anesthesia and other effects associated with the stress. You really cannot conclude that multiple anesthetics is a marker for conditions that increase learning disability risk. There. So, have I made my points absolutely clear over here with regard to this data? Because what really is important is not the retrospective studies, but the 2 prospective studies that have currently occurred there. And this I'd like to point out is the study coming from JAMA, which is a prospective study of 105 sibling pairs where only one was exposed to an anesthetic for it. They did a very detailed neuropsychological battery over it, and this has come out just in about 4 months ago. What is fascinating about is this is a very important point. There is no statistically significant difference in mean scores between siblings in memory, learning, motor processing, etc., etc., etc. But the better study, and the one there, is the randomized study of awake regional anesthesia versus general anesthesia known as the GAS study. The results at the 2 years over there were the patients who were assigned randomly to one of these 2 forms of it were done, and these results of the secondary endpoint, if you look at the cognitive composite scores of 98.6 plus minus 14.2 versus 98.2 plus minus 14.7. Look at this. From minus 2.3 to 2.64 is the 95% confidence interval. So it looks that evidence clear that at least for anesthesia below 1 year does not seem to cause problems. There are 2 other studies underway, which are really getting the results in the 2 years. One is the Mayo Clinic study, looking at exposed to no anesthesia, 1 anesthetic, or multiple anesthetics, where they will be getting this right there, using this test of battery. These results should be coming out within the next 2 years. There's another study which is going on in the UCSF, which is planned to do it to find out if long anesthetics have a problem effect there. When we have all of this data, we can state then that yes, this is nice what happens in rats. I'm sorry about what happens in monkeys, but we don't need to worry too much about what we've been doing. In summary, non-clinical findings in animals shows as mounting evidence of anesthetic-induced toxicity. These possible safety margins occur, and the greatest concerns is in the longer duration, younger patients having multiple procedures. The conflicting results for single exposures in the retrospective studies, but those with regard to the young patients, there's good evidence that a single exposure for a short time is safe. The causality cannot be expressed. We don't know whether it's surgery, anesthesia, or both. It's interesting that in December 2006, the FDA mandated a warning on all drugs, anesthetic drugs, with regard to this. And it comes out with health providers should balance.
लंच के लिए आपको चलना पड़ेगा हमें सिस्टम पता है आप समझ है ना पूरा सिस्टम उससे कोई मतलब नहीं है इसका। हेलो, कौन बोल रहे हैं? आईटी सेल में कंप्लेन करी कंप्यूटर के लिए। हेलो, हाँ भैया अभी कर रहे हैं टाइम लगता है उसमें थोड़ा सा, ठीक है। आते हैं डेटा सेंटर में, लगा देखा ऐसा उसमें डायरेक्टली फाइबर लगी नहीं थी। एक मिनट देख लेते हैं जरा,
लगा सब सेम।
लैन आया नहीं, लैन कनेक्ट करो, लैन
लीजिए।
हेलो
लाइन क्लियर है
भैया, आते हैं कुछ काम करवा रहे हैं, ठीक है। अरे और भी जगह काम है, आपके यहाँ कर दिया गया है, कुछ सामान कम है, आ जाएगा करवा देंगे, परेशान ना होइए उसके लिए। चलेगा 7 का चलता है, 20 का चलेगा यहाँ तक। हेलो, आप कौन हैं, कौन बोल रहे, क्या नाम है आपका? अच्छा सर। पावर बैंक वैन कुछ हो?
पावर बैंक तो मेरे पास है, लेकिन तो केबल
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 पावर बैंक
केबल
केबल
से-
फंसा चाहिए।
केबल मिले तो इसे कनेक्ट कर देंगे।
मेरा फोन पावर बैंक भी है, नहीं है। हाँ
नहीं हम देंगे, हमारे पास रहेगा ठीक है। मैं वही 400 में केबल। हाँ
चार्जर केबल
चार्जर बोल तो आपको करना हम उधर से पता चलिए कौन सी प्राइस है। 6 को 6 किलो 6 को कम से कम 2 का 6 को 6 जो 48 की होती है उसमें क्या करते हैं अंदर जो सीट आते हैं वो अलग अलग तरह के मतलब पेयर बना के अंदर से ही है 6 में 6 बजे नेट पे चाहिए हो
नेट यूज कर रहे हैं
और मिल कर रहे हैं
कर रहे नहीं हम अपना ब्रॉडकास्ट कर रहे हैं। और बताया बस उसको प्ले ना करिए
ना करें
लेकिन बैटरी तो अभी बनी है मोबाइल पर क्लिक नहीं सही है मोबाइल डाउट चल मेरा जियो स्लो हो गया उसमें क्या क्वालिटी में
विकास भाई विकास भाई
वही ना
क्योंकि आधे घंटे का है वो नेट बंद कर दो तुम नेट बंद कर दो
तो उससे कुछ फर्क नहीं पड़ता ना
नेट बंद कर दोगे अभी चलना नहीं है ना
नहीं तो 1 घंटा टाइम से है ना कोई फर्क नहीं पड़ता
अच्छा 1 घंटे से ऐसा नहीं कि आधे घंटे आएगा
कोई नहीं आप फिर से कर दो
नाश्ते पानी की व्यवस्था है नाश्ते पानी की व्यवस्था है
क्या शुरू हो गया क्या हैं थैंक यू बोल चुकी है
मतलब बस वो डर लग रहा
बैड आ रहा है देखो
प्लीज चेक कर लीजिए सही आ रहा है कि नहीं
नहीं बैड आ रहा है
नेट चल रहा है उसमें ठीक से
अटक रहा है
मतलब ज़्यादा बैंडविड्थ चाहिए उसको जो मिल रहा है 5 MB मिलते ही रहा
ज़्यादा चाहिए ना
और चार्ज 3G है और 4G नहीं है
अच्छा 4G नहीं है
अब 4G वाला अब तो है सेट तो सिम डाल लीजिए 4G से उसको यूज़ करिए तो 4G की और तो स्पीड बढ़ जाएगी इससे वोडाफोन 4G दो सिम
4G है क्या
हाँ 4G से एक तो पे नहीं मिलेगा
भी चल रहा है हेलो हाँ हेलो हाँ हाँ बसो मैं ये कह रहा था ये इनसे बात कर लेना ये करण से
हेलो आपका 4G फोन है ना 4G है तो उसमें लगाइए और तो 3-4 गुना और बढ़ जाएगी वो नहीं
क्या बता रहे हैं? वहाँ पे तो वेल्ड है। आपके यहाँ पूछा है किसी और से, तो सर्विस में प्रोग्राम चल रहा है, कल भी ले सकते हैं। ये वेल्ड है कुछ इसी में, और निकाल सकते हैं, 1-2 दिन में लगे तो निकाल भी नहीं सकते। प्रोग्राम
इसके नीचे पावर कौन सी लगती है पीछे? डिटैचेबल में लगती है?
ये बोल रहा है। निकले भाई फिर हम
निकलो।
लोग। कोई भी ऐसी प्रॉब्लम होती तो लाइसेंस के तो कोई मतलब नहीं है, अब कोई मतलब नहीं है। लिंक आ ही गया है, अब कोई मतलब नहीं है उसका। बाकी आप अभी ये काम पूरा है इस पे।
ये तो 2 मिनट अब ये वहाँ पे गए हैं, वहाँ तक एक बार हम कंफर्म करवाएंगे।
लिंक अगर ऑन ना होता है मतलब वहाँ से
नहीं वहाँ से बस ये देखो स्विच मिल रहा है, बस एक मिनट ये देखो।
हम जब तक वो लेके आ रहे हैं इसकी पैकिंग वो है नाम जल्दी आ वहाँ निकाल सकते हैं, कोई दिक्कत
नहीं
है? नहीं निकाल सकते हैं।
नहीं
साउंड का इनपुट कहाँ से आ रहा है?
साउंड आप देते
साउंड एक्चुअली तुमने जो बोला था ना बंद करो आधे घंटे का ही है, वो यहाँ वाली साउंड क्लियर आ रही थी, और जो उधर बोल रहे थे वो साउंड बिल्कुल ही क्लियर आ रही है। इनपुट मेरे ख्याल से
So, in this journey of mine in pediatric anesthesia, there have been many colleagues of mine who have learned along with me. And the 30 years in this institution have been the most joyous experience of my life. There were many, everybody would have realized or heard anecdotal reports, something happened with him like this, something happened with her like this while anesthetizing a child. The disincentives are cognitive and behavioral. I would say that it is easy for me to stand on this podium and say that everybody should report a critical incident. But then what happens to the individual? It's a devastating experience for anybody to have a child either having an ambiguous outcome of death or some permanent disability. Legal issues are there both for the institutions as well as individuals. And most of all, the feeling of personal shame that he's going to be, people are going to be critical of him or her when they report a critical incident. This is the main psyche. All of those of us who have experienced a critical incident, it could be a devastating period for a long while. In fact, we would be afraid to touch a patient again. Now, there are many system reasons also why we do not report it. I may have had a critical incident, but where do I report it? How is it taken? Really, is it going to be useful for analysis? These are the questions that come in many minds. And institutions are very wary if you want to report a critical incident. History of critical incident reports dates back to the World War II. If not in the medical healthcare system, it was very popular in the aviation industry. It was popular in the other industrial accidents also. Colonel Flanagan was the one who made it possible for the present day critical incident reporting. The aviation safety reporting system was established by NASA in 1976, mainly targeting the aviation accidents and industry-related accidents. The paper by Cooper et al. Applied critical incident techniques in anesthetic practice to analyze errors and equipment failures also. In fact, all the models of, all the safety norms of anesthesia, and even in our training, we talk a lot about the aviation industry and the way they have the checklist. Yesterday's lecture on Tom Hanks' movie was really, actually we follow the aviation incidents very closely. And if you read many incidents, and there's a beautiful book by Outliers by Malcolm Gladwell. That is the one which he talks about aviation incidences, how the cultural differences and how we communicate also kind of contribute for an accident to occur. Actually the World Health Organization was the one, where you see that there is an impetus and inspiration to do something in this direction so that the quality can be improved. Occur 3 to 8% of all anesthetic, revealing a high non-fatal rates of events occurring. This is a very high rate actually. I think, Dr. Subramaniam, I need some help on your computer. Can I move this cursor? That's separate. Yeah, that's what. This one? This one? Yeah, sure. Thank you. Sorry for that. I'm using his computer and so. And I would like to the demographics. The 24 perioperative anesthetic mortality is something which is related to the Human Development Index. This is what the World Health Organization has reported. And there are countries. It is said that in the countries where the development, like in the South African Journal of Anesthesia, they have said that the mortality rates are very high in the developing countries. In fact, the number is, if it is 0.1 to 1.2%, make a concerted effort as far as the reporting of critical incidents is concerned, to see that critical incidents are reported. There is a paper, I think, I wonder whether the audience, somebody is sitting who have formulated this. It's a good paper which has come out in 2016 in the Indian Journal of Anesthesia. And now how do we report? This is all very good to say that we should be reporting. In pediatric anesthesia, generally in the anesthesia reporting in the adults also, and more so probably in the quality and safety healthcare journals, you see several models being reported. But we all see that before all the contributing factors, they may just result in an event, but to see the outcome, all these factors should align themselves. This is how you report them. Patient-specific, contributing human factor, contributing latent factor, event type. What is the event that has a medical outcome, and of them met all the inclusion criteria? That shows how unorganized probably the reporting system is for us to know. The severe complications are poorly defined with a large variation in specificity of diagnostic reporting, even within the studies. As I was saying, this is probably among all the literature when I looked into it, this is a very exhaustive reporting system. I believe in Netherlands they had the 20-point respiratory incidents followed by this. The other columns have not been reported, not because probably they may have occurred, but then as I said, the formatting, where they reported them, but they could not probably be fitted into this kind of a format. But we see that the respiratory events are the maximum. And when the closed claims were analyzed during from 70s to 1990s, it was found that the earlier part of the century, like when the respiratory events were more, between 1970s and 80s, whereas the cardio was also some of the events that are. And seizures was a very common. Now I wonder why we are not hearing about it. Is it because we stopped using the drugs which we probably, scopolamine and I have not used scopolamine. Atropine was used very commonly in the beginning. In fact, we would always pre-medicate the children with atropine. And when I now look back, I'm surprised at how practices change. I have stopped using atropine at the induction. In fact, no drying anticholinergic agent at all. But then all the same, the reports about this have come down. And pardon me, all gray hairs tend to reminisce a lot, I think. So. The laboratory results, the events to be reported in this, electrolyte disturbances, anemia, I would not like to go into the details of this, equipment related. Failure, unavailability of equipment, and then unsuitable for the purpose, without user training. These are all very common in the equipment related failures. And monitoring equipment is the one which fails the maximum across the board when we say that the monitoring equipment has failed while reporting a critical event, and of course the non-availability of itself of the monitors. Regional anesthesia is one of the most safest in pediatric anesthesia. The events that are reported are more training related or the complication of a particular technique, but is considered to be the safest, and we see less of critical incidents being reported. And with the popularity of ultrasound and guided blocks, they should be disappearing all. The slide may disappear after some time. Lesions. Well, in this, the only thing the skin and accidental removal of course, this I don't want to. The skin related lesions relating to most of the babies who come from the NICs. Like when we talk of cannulations and all that, we talk of an expert anesthesiologist, pediatric anesthesiologist doing. But when the babies come from NICs or from the wards, newborn babies for not requiring NIC care and all that, we see that the junior most person would have tried. In fact, the trainee nurses train. So by the time the baby comes, you would have they would squeeze the hand to visualize the vein, so the bruises under the skin. And we are wary of taking up the child lest this be interpreted as what we have done in the OT. So this is very common, and multiple punctures on the hands of the newborns, including newborns, everybody. It's pathetic to watch these babies. These are, these are also reported as critical incidents only. Because when the mother is handed over the baby, I'm sure the bruises will have to be accounted for by somebody. Medication. I wish I could go back to the first slide, but I won't like to disturb this presentation because I'm not familiar with the computer. The medication-related issues. Maximum reports, if you compare the results from many countries that have come, medication-related issues have been reported in a UK paper. Maximum number of percentage has been reported, and it looked, for me, from Hyderabad, it looked that it cannot be happening in UK at all. But then it is so. That means all of us are prone for the same attitude that goes into medication issues. Dilution, most of it is dilution. We do not dilute, even in pediatric anesthesia, as Subramaniam was mentioning. The kind of dilution we ought to be doing for a newborn baby and a 3-year-old or a 10-year-old is totally different. So medication issues are mostly this. And when to do the top-ups. Why we get into a problem is, when do I do a top-up at the end of the surgery if the relaxation is required? I do the top-up and the surgeon says the case is over. I have to wait, I have to wait. But when we don't wait, we get into a problem. Of course, failed communication is a huge issue. As I said, communication is a huge issue, not only in the wards, like they don't take our orders, fast the child for 3 hours, and then we get a child who's been fasting for God knows for 7 to 8 hours. कुछ नहीं दिया, रात से कुछ नहीं दिया is the thing which the mother will tell, and we would not know why the communication has failed. And one more thing is, even in the OTs, see, the mistakes can happen in anybody's, in a consultant hand, in a resident's hands, anybody. We, as yesterday, the lecture on, I will go back to his lecture because I was very impressed with what he said. Communication is very important. About the Sully, the Tom Hanks movie, I'm sorry if I'm not able to quote the doctor's name, but what happens is, if somebody doesn't say, I know, I am seeing that the tube is not in, but I won't tell because he's senior to me. This has happened to me. I have done that mistake. I kept quiet because I know the tube is not done. So the communication, encourage them to anybody to speak up and tell when something is wrong is happening. Anybody can make a mistake. I will go over this slide because I know these are all complications which they are for the sake of a list. So of course, it remains an issue till now. Whether it should be reported. So some people, in all this list of events, you may think that some of them are minor events, some of them are major events. But then it is such an exhaustive list that everything has been taken into consideration. And I patiently went through these, the classification of these events, because I thought that it should give a direction to people who think that we should be reporting all these incidents. Which phase of anesthesia do the critical incidents occur? During surgery, the incidence is quoted as 52.4 and 32.8 as following surgery. Not doing much in Indian, but it is slowly catching up as we start doing in the OTs. We are doing a lot of dental anesthesia, but not in the true sense of office-based. At least I don't have any statistic to quote on that particular subject. Now, what are the factors that contribute to the critical event? And there's some patient-specific factors, some human factors, and of course, organizational and systemic factors. I would simply try to tell you that children below 1 year of age, all of us have, even the earlier speakers have pointed out that they are more prone for critical incidents. And this is identified as a high-risk group. Most often, fortunately, for the anesthesiologist, in a newborn, I'm sorry I use the word fortunately, because, but then you tend to take a deep breath. I am not the only one who kind of set up all these things. They are in the neonatal ICUs, and they have been already treated by so many clinicians prior to you. And then what happens is the morbidity also in these babies is so high because of their primary issues that ultimately the outcome is the critical events when they occur. They are not only anesthesia related, and they get aggravated certainly aggravated by anesthesia-related events. In fact, the Japanese Society of Anesthesiologists have suggested that the general pediatric anesthesia was conducted safely in all the hospitals. But if they had a low volume of pediatric anesthesia volume also. But the exception was the newborn anesthetic procedures. They clearly said that the mortality was high in hospitals with an annual newborn anesthetic volume of less than 12 patients. Of course, ASA grading matters. We all know that grade 3 to 4 children are at a higher risk of critical events than the grade 1 patients. But though the earlier studies all said that the maximum events occurred in the grade 1 patients actually. And the 2001 Singapore study, I think, was citing that the maximum of events were occurring with grade 1 patients. Now the human element. It's a beautiful thing that we become an obstacle in our own endeavors actually. In a 6-year study period, human factors 58.5%. This is a last year journal, it's a Korean study. And they cite a 58.5 human factor related events. And this is, of course, this cites it as 42.5%, very high statistic. 53% in this study. And so all of them are closing on, if you average them, they were closing on a 50% human factor related issues. This is from the essay on criticism from Alexander Pope, and it's one of the most often quoted quotations as far as the disaster area is concerned, critical events, industry related, aviation related, everywhere, very often. I don't know why. Because the second half of the quotation, when something happens in a medical, in a nursing home, and a practitioner, when the anesthesiologist was single-handed, I was only called for a help later. So the contributing factors are latent factors, but then the human error, failure to check that he was so engrossed in doing getting the tube in, that for a moment he was completely detached from what the other things which were related to the patient. The outcome is a major injury and it's a permanent damage. I know death is the unambiguous, it's an unambiguous result of a damage. This is a 5-year-old again for an inguinal hernia repair. At the end of the surgery lasted for about 20 minutes or 25 minutes at best, if you probably include the anesthesia time also. The surgeon at the closing of the incision, he realized that there was crepitus in while closing. And then he had alerted the anesthesiologist and they took, fortunately there was no desaturation or anything during. The anesthesiologist were unaware that something was happening. So when they found that there was a crepitus across, they checked and they said bilateral pneumothorax was seen. The only event that happened
बहुत वेरिएशन है यार
चल गया जियो चल रहा है
नहीं तुम्हारे वाले से
पास ही रखो
Thank you, madam. Thank you very much for being here as a speaker for the orator. It is a really great privilege for us for the IAPA, and she would be really mentor for this. Thank you, everyone. So I request for the next session to go.
Good morning, everybody. I am thankful to the organizers to just give me 2 minutes to make a short announcement here. I am here to announce the next National Airway Conference, that is NAC 2017, which is going to be held in New Delhi from 8th to 10th of September. This is under the All India Difficult Airway Association Delhi branch. It will be held in All India Institute of Medical Sciences, with hospitals pitching in. And you are all aware that just like the guidelines in pediatrics, the airway guidelines have been laid down by the IDA last year in Vadodara. They were discussed further there, and the final copies are now available on the web. It was finally finalized at Tata Memorial in December. So our theme is going to be from guidelines to practice. So I invite everybody. The portal for the conference registration will open very soon, and on the lighter side, not too far away from Lucknow. So all of you are please requested to come and attend. It will be a good scientific session. Thank you.
IAPA. I think you're all aware that we are in the process of increasing the life membership fees, and after this conference is over, it's going to be hiked from 4,000 to 5,000. So please use this opportunity, those of you who are not yet members, to enroll into the membership. And second, I request all of you to attend the general body meeting today at 5 o'clock, because you all are, important for us to know what needs to be done and to know what all we are doing. So please join us in this hall at 5 o'clock, and also register for the next conference in Hyderabad. And now there is an easy payment facility. We have a swipe card, so you don't even need to pay cash now, and you can instantly get receipts for everything. Thank you.
I would like to invite Dr. Nirja Bhardwaj for the webcast.
Dear colleagues, it gives me great pleasure and a sense of pride to launch fasting and minimum monitoring guidelines under the auspices of Indian Association of Pediatric Anesthesiologists. The idea of formulating guidelines by IAPA was discussed in various executive meetings, and finally it took shape during the 2015 executive meeting at Hyderabad. After discussing their willingness to work on these two guidelines, Dr. Anita and Dr. Ekta Rai consented to help me with this. All credit goes to these two colleagues of mine who have taken time out from their busy schedule to make this venture a success. Guidelines are systematically developed recommendations that assist the practitioners in they assist them in making decisions about healthcare. These recommendations may be adopted and modified according to clinical needs and constraints. It was felt that guidelines existing in the world literature could be modified to suit Indian needs and resources, as well as provide safety to these group of patients. The present guidelines have been made keeping in view the level of evidence for the existing knowledge and modify them accordingly to the Indian context. The fasting and minimum monitoring guidelines were formulated first as it was felt that they may have the maximum impact on the management of a child who may be getting operated in all types of hospital, right from institutions, private hospitals, nursing homes located in big cities and small towns. These guidelines will be available on IAPA website and can be accessed by both members and non-members. As medical knowledge will evolve, these guidelines will be reviewed from time to time, and also it will be open to suggestions made by various IAPA members. I will now invite Dr. Anita to please speak something on the fasting guidelines, and this will be followed by Dr. Ekta, who will present the minimum monitoring guidelines.
Thank you very much, madam. Just taking time to find out. Yeah, got it. So good morning, everybody. My colleagues, teachers, and I'm Dr. Anita Nehete. I'm from Nasik, Maharashtra. Yeah. First of all, I want to thank the organizers for giving me this opportunity to present the guidelines, and to Dr. Neeraja, madam. Yes. So basically, what are guidelines? Guidelines are recommendations based on scientific evidence that helps the clinician to take certain decisions. But they may be considered as standard practice. They can be modified depending on the clinician's experience and depending on the local practices. The guidelines also need to be revised from time to time in view of the new scientific evidence. And we must remember that they apply only to healthy pediatric patients, including neonates, for elective surgery, under general anesthesia, regional anesthesia, or sedation. But the guidelines may not apply to all patients. The patients who have problems with gastric motility, for example, with the congenital hypertrophic pyloric stenosis, the patients with trauma, the patient with bowel obstructions who have increased, we know that they have problems with motility. So what is the purpose of formulating guidelines? In spite of recommendations and guidelines, we know that till today also there are many pediatric patients who are fasted for many unnecessary hours than is required. And it happens in my hospital as well as your hospital also. And simple steps like education of the ward sisters and more improved communication between the anesthetists, the surgeons, and the ward nurses and the parent is all that is required to assure that the actual fasting period is reduced for the children. So the guidelines will increase the patient satisfaction, patient comfort, and of course the patient safety. And they are supposed to avoid delay and cancellations. The guidelines, if followed, will decrease the risk of dehydration as well as hypoglycemia. They promote good clinical practices and formation of protocols, and of course will reduce the severity of pulmonary aspirations if it occurs. Now we have gone through the scientific evidence, and as we all know that the category A is a supportive literature, category B is suggestive literature, and C is a equivocal, and D is a insufficient literature. Now we come to the preoperative fasting for guidelines for clear liquids. And what is the recommendation? that the children should be allowed to drink for up to 2 hours prior to elective procedures. Now, what are clear liquids? Clear liquids are water, simple water, glucose water, any pulp-free fruit juice, apple juice, any clear sharbat, carbonated beverages, even tea and coffee, but without milk. And what is the scientific evidence? This is a meta-analysis in the Cochrane database, and it is a clear evidence that patients who are fasted for clear liquids for 2 hours have lower gastric volumes and higher gastric pH than those fasted for 4 hours. 6 hours is because it is difficult to define what is a light meal, and there are really no recent studies for solid food. But we know that gastric emptying depends on the type as well as the amount of food. So it is advocated that for solid food, we advise 6 hours fasting for all patients. And most patients will accept this readily if they are allowed to drink fluids for up to 2 hours. And it is widely accepted that fasting for a large meal containing fatty food, meat, should be 8 hours or more. Now, what about the pharmacological agents? We tend to use many of these gastrointestinal stimulants like metoclopramide, the H2 blockers, antacids, and antiemetics. And what is the recommendation regarding these? Is that routine administration of these multiple agents to children who have no increased risk of pulmonary aspiration is not recommended. The postoperative resumption of fluid, the recommendation is that gastric volumes are directly proportional to the risk of pulmonary aspiration. But this may not be true. And in clinical setting, it is very unlikely that all of the gastric volume will be aspirated. So it will be really helpful for us in Indian setting also to conduct audits in patients who have had pulmonary aspirations, and then depending on the result of those audits, to formulate or change these guidelines regarding the optimum fasting intervals. So this is a summary of fasting guidelines, 2, 4, and 6, and 8 hours. And thank you for patient listening.
Good afternoon to one and all. I'm here to present the guidelines formulated for minimum monitoring standards. At the outset, I would like to first tell how we came to make this, what was the methodology for these guidelines. First of all, the need for the guideline was felt by the IAPA seniors, I must say. And then the job was allocated to a team. It is a teamwork. We put up the framework, and the framework was presented to the executive committee in August last year, 2016, in Mumbai. The framework was modified, and I'm presenting you the final version of the framework which we finally put forward. This is the overview how we are going to discuss the guidelines, what we made, the aims, the definitions, the guidelines. I must thank Dr. Agnes, I must thank Dr. Prabhavati, because they have done the introductory part for me already. All the numbers have been quoted, the discussions already happened. So I will not go back into that again. So I'll put forward as, according to the census, Indian census 2010 and 11, we have the absolute number of 472 million children less than 18 years in our country. Huge number. So they are coming for surgeries. Anesthesia is a crucial part of surgery, and the safety involves caring for these children in our hands. Coming to the child and adult ratio, in India we have this ratio of around 39+%, which is so much higher than the other developed countries who actually talk about pediatric anesthesia more than what we talk about. These are various facts. I will just name and go forward. Children are not small adults. We have enough had discussion on this. The incidence of mortality, morbidity is much more higher for neonates and children, as ma'am has already said, and she has put forward some numbers already. Continuous monitoring has resulted in reduction of morbidity and mortality. We all know that. And it is essential to emphasize the need of minimum monitoring standards in our Indian context. So IAPA believes that guidelines are only suggestions and the decision about the individual patients are to be finally taken by anesthetists in the best interest of patient. We decided to define few definitions which I'll come to in my few next slides. This is not the aim of the monitoring guidelines, but it is the aim of IAPA to ensure safe and optimal anesthesia for each and every child in our country. This ultimately should lead to reduced morbidity and mortality throughout the country. The dream what we pursue is the ultimate goal to reach nadir mortality and morbidity. Hope we reach there at some point of time. Now, coming to few definitions, it's very essential to define these terms because what all guidelines are available in literature available to us is all Western country. And we are a little different from them, though the safety for the children stays the same. Safe child in Western country, in our country, the safety stays the same. But there is a different way to go about it. Vital monitoring, we have defined vital monitoring as a high priority monitoring, which is essential and crucial for the safe anesthesia. Desirable monitoring, the monitor which finally leads to improved outcomes by fine-tuning the anesthesia management. Who is an experienced anesthetist? The anesthetist with at least 3 years of experience in anesthesia, post-degree, and who are keeping themselves updated by regular reading and practice are experienced anesthetists. Who are the pediatric anesthetists? It has been taken from European guidelines, but we have changed the numbers as per our setup. The anesthesiologists who have extra training of at least 1 year in specialized pediatric centers, who anesthetize either at least 30 children per month or equivalent to 2.5 days, caring for different ages in pediatric population. Pediatric anesthesiologists are expected to keep up to date and maintain competence in resuscitation, anesthesia, pain management, emergency pediatric medicine, and initial stabilization of children requiring intensive care. Now coming to the guidelines, the foremost important part of our guideline is the anesthesiologist, the availability of anesthesiologist, and what is the role of that anesthesiologist. The presence of an anesthesiologist throughout the procedure for anesthetized child is mandatory. The anesthetist must ensure that all the appropriate equipment which he or she is going to use have been checked before use. And the same standards regarding anesthesiologists holds true for sedation, regional, and for remote locations. It was felt desirable for same anesthesiologist to complete the anesthesia, wake the child up, and then shift the patient to recovery for monitoring. If there is a shift system in place, then all the information related to patient should be handed over verbally, apart from documentation at operation theater to the next anesthetist, which includes medication, events, special issues related to patient. Patient should be monitored by anesthetists continuously until the patient is shifted to recovery. And then they are taken care by recovery nurse with the doctors available to handle the emergencies. All the patients should be discharged to ward from recovery by doctors. Documentation is essential part is an essential part for the safety of the children under anesthesia. Legible, clear data documentation for all the intraoperative events, including the vital signs at 5 minutes interval for monitoring periods, should be maintained, and the monitoring should start from the baseline reading and should finish at recovery. Now coming from anesthesiologists, coming to equipments. We need to have minimum monitoring standards for general anesthesia, which includes heart rate, non-invasive blood pressure,
To be asked to speak at this conference, and particularly flattered to be asked to share this session with Professor Moraro, who has investigated and published widely on the topic of ventilation in pediatrics and pediatric intensive care. So when I started my career in the early 90s, these are the ventilators that were used in the operating theatre. We had the clunky Manley minute volume divider and the Pedalon Nuffield. And last week I anaesthetised a child at the Mater Hospital where I'm currently working, and I ventilated him with this, which is a Campbell